Right. So we're going to transition to our next guest speaker, Dr. Beth Meyerson. Dr. Beth Meyerson is a professor at the University of Arizona who focuses on harm reduction and sexual health policy and systems in the College of Medicine Tucson within the Family and Community Medicine Department. She also directs the Harm Reduction Research Lab. The lab's transdisciplinary faculty include 9 researchers from universities, some with lived or living drug use and or drug treatment experience. Beth is also the policy director for the Comprehensive Center for Pain and Addiction and faculty of the LGBTQ+ Institute at the University of Arizona. Dr. Meyerson has led several funded studies focused on sexual health and harm reduction at the systems and policy level. Her current work is funded by the NIDA and the Vitalist Health Foundation. Beth works closely with an Arizona-based statewide group of people to build the evidence edifice to change practice and policy to improve health of people who use drugs. The Drug Policy Research and Advocacy Board is this group and includes MOUD providers, people on reduction organizations, and university researchers. Dr. Meyerson's expertise is community-based participatory action research, implementation science, translational science focused on medicine and pharmacy practice. Beth directs a postdoctoral research program for Indiana and for Indiana for maternal child health disparity research focused on building the pipeline of by POC researchers. And recently, Beth was named the Len Dittmanson Humanitarian Awardee by TMC, and she was also named a Women in Medicine and Science Torchbearer. Thank you for joining us today.
That's really nice, Aurelia. Thank you. Hey, everybody. It's a pleasure to meet with you, and I look forward to our ongoing discussions. I'll have a slide at the end with contact information, and I want you to feel free to reach out. And thank you, Brenda, for all the work you're doing with CHEC. It's so very, very important, and I appreciate just the personalization of it so that it's grounded in what's real. Many things can happen in 5 minutes, once every 5 minutes. And by the time we finish talking together today, this will have happened at least 12 times. Every 5 minutes, one person dies of an opioid overdose, dies. And granted, I'm hopeful based on some recent CDC data that has emerged, but we can talk about that later on. So one person dies of an opioid overdose every 5 minutes in the US. And this is why I do the work that we're going to talk about today. But I want to inspire you as change agents to be working in the areas that mean something to you. So I have 3 take homes today that really are, I'm just hoping at the end of this is what you'll get. You're going to hear examples from our harm reduction research lab, 3 of them. And you'll see how we do the work to affect structural change. You'll understand what that means. You're going to hear about how we are a village. We don't do this work alone. This is not about me. This is not about I. It's not about Beth. And you can do this too. And think about your village. And then I want you to try it at home. Try this stuff at home. It's not rocket science. If we can do it, anybody can. And we are just not trained in this way through our traditional curricula and programs. So you find places like our lab or other places to get this kind of training. And I recommend that you seek it out. So let's get focused. How do we make change? And this is the question. It's the question that motivates me. It's the question that's motivating our team and our partners. And so it starts with us. And what you will decide is your role in change. So think about this as you hear of our experiences today. And I don't think, by the way, that this question is something you should ask yourself later. Like you might say, oh, I'm just a student, or I'm just a medical resident, or I'm just an early faculty member, I'm just a staff member. Nope, sorry. Everybody has a role to play in making change. And we each have privilege. You've heard a lot about this from our colleagues on the video, obviously all through Brenda's talk. Everyone has a role to play. We can use these privileges to leverage it. We just need to recognize what they are for us, listen for the change needed by deep engagement with others who are working on change, and identify the points of leverage. This is not a spectator sport, by the way. So our lab, you heard a little bit from Aurelia about our lab. These are structural changes that, this is the work of our lab, the Harm Reduction Research Lab. We're located in the Department of Family and Community Medicine, which I love because our tagline is social justice through medicine. And I think probably a lot of people on the call would appreciate that. Our lab is focused on systems and policy, and you've heard a little bit about what that means today. I love that our colleagues who are speaking, we're talking about big P, small p policy. We're interested in policy, which is law. We're interested in regulation, and we're interested in the practice of medicine and pharmacy. So and there are structural changes that have our focus for the past 2 years. I'll give you a few examples. And if you want to know more about this, just head over to our lab page or my YouTube channel. I used to teach public policy and advocacy at Indiana University. I'm sure I have some dusty stuff. You can look there to get some background about what I'm talking about. So if you think about structural change, there is a relationship among all levels of change. And on the right hand of the slide are things we're working on right now. Legislation is an expression of big P policy. This means passed by those who are elected. And right now, in this field of harm reduction, Congress is working on MOTA, Modernizing Opioid Treatment Access Act. This will completely change the way methadone medicine is delivered in the United States to align it more closely with several of our peer countries. Regulation is a small p, but don't make no mistake, it's got a big impact because it's promulgated not by elected people, but by government agencies. And as I say, there is no regulation without legislation because we can't regulate what we aren't given the authority to do by elected representatives in this case. So remember, where there's regulation, there is always enabling legislation. Systems behave based on the environment in which they exist. So market environment, surely, but also policy environment, what's allowed, what's illegal, what is reimbursable. Systems reflect regulation. A law will be passed, but we all wait for the regulation because that's how the boots hit the ground. And then finally, practice, in this case, is about medical and pharmacy practice for our lab. Something might be allowed at one level, regulation, but the system isn't reflecting that when studied at the practice level. You'll see some examples of this. So we are about translation. We don't just do science, meaning that we don't just study phenomena and develop interventions and test them. We take the time to translate data to information that will inform change. This isn't someone else's job. We're not stopping at the journal article or the grant that we wrote or whatever. We decide we're going to take this all the way through. And so that's very important because it then becomes information that can be used by a pharmacy board regulation, by a governor's office, certainly big P policy, by a number of colleagues that will inform systems change that will affect the things that matter to us. So note to self here, you should be able to explain. And by the way, we train our people in the lab and our students to explain studies and translate data to information. So at any time, you should be able to explain your study in an elevator to a complete stranger. I used to make my mother do this with my PhD students. Very important. And again, not rocket science. So you might not know what harm reduction is, so you can certainly scan that QR code. There's a quick interview that was done by the Comprehensive Center for Pain and Addiction on harm reduction. This is a picture of naloxone. But I will tell you, why are we focused at the structural level? It isn't that we don't care what individuals do. We care more about the structures that set the boundaries of the environment of choice for individuals to be healthy and to thrive. So it's not enough to know, for example, that Beth can use naloxone, the medication that reverses opioid overdose, and pictured here. It's not enough that she can use it when she's with someone who might be falling out or having an overdose. And by the way, that's very important because we know the majority of people who overdose are in the presence of someone else. And so it's very important that we have it. What we do is we care about whether Beth lives in a community where naloxone is accessible. Brenda was making the same kinds of arguments. If you live in a community where food is not accessible, where water is not accessible, where safety is not automatically baked into the cake, then you can't possibly thrive. So what I'm going to say to you here is that if you're watching, and this is our first example, and this is naloxone access in Arizona. If you're watching policy change, you'll know that since 1971, naloxone was available by pharmacists, to pharmacists, paramedics, et cetera, for their use, for dispensing with high-dose opioids, stuff like that. As time went on, as we saw waves of opioid epidemics, heroin, et cetera, it became available more readily, schools, first responders, treatment programs, harm reduction programs. And then in 2023, it was finally approved as an over-the-counter medication. But here's the thing, it's expensive. And not everybody can get it for free. Not everyone has insurance. Not everyone lives in a community where there's a syringe service program or a dispenser of this. And here's what's important about the science that we're all able to do together. The public and policy belief is that naloxone is sufficiently available in communities through the state subsidized distributors, meaning organizations that get free naloxone from the state. That's not true. In 2021, we documented that over half of those state distributors in Arizona and Indiana, in fact, we did a 2-state study, more than half of them did not allow layperson access. So they had it, but the people weren't getting it who really needed it. So what about pharmacies? Pharmacies are ubiquitous, they're everywhere. How about that? And according to a recent study, a census study that we've done for pharmacies, and a census study is a study of all the pharmacies, for example, in Arizona, all 932 of them, 101 of them were wanting to dispense subsidized naloxone. They were happy to do that. They know their patients could use it because their patients can't afford it. So this is very important. The federal policy, Drug Supply Chain Security Act, had to be changed to allow pharmacies to stock and dispense something that didn't come through their usual medication flow. So the Food and Drug Administration passed an exemption in 2022 to allow pharmacies across the United States to do this. This is important, but it didn't happen right away in Arizona. In fact, we tripped over this in a NIDA-funded study that we were doing to get syringe access in pharmacies and to help pharmacies increase syringe dispensing in a non-stigmatized manner. We wanted to put subsidized naloxone in the hands of these pharmacies because they wanted that. And we learned that in Arizona, quote, "We don't do that." So the pharmacy board told us at the time that they weren't interested in any of that. We did educate them on the FDA exemption. That was not sufficient. So we brought years of our naloxone research to the table, not sharing our papers, not, drowning them in data, but making an information brief for them. And the governor's office was involved as well to talk about why that's important, so that there was actually a need and a way to fill that need so that we could really make a difference in opioid overdose death. So what happened was the pharmacy board agreed that they would support this, and that small p became big P because we had to change the Arizona law governing pharmacy ability to dispense naloxone. So that happened last year, but the work still continues because now back to system, behavior, and practice. Not all suppliers of the subsidized naloxone believe that pharmacies should have them. So we're working now with pharmacies and their county health departments and the state health department. Maricopa's rocking it. They're doing really well. And I've got future pharmacists working on that who are students in our lab. So this is one example of how we work. We bring our research to the table. We're working with our partners to identify and talk about a process that will be able to make some structural change. But I'm going to shift gears to focus on the village here for a moment, because I didn't come up with this with myself. This is not about what work Beth wants to do. We do our work with guidance from a statewide group of people called the Drug Policy Research and Advocacy Board. It was actually named by a really great friend of mine who died 10 days ago, Chris Aber, just a great human. We do this work and we center this work on the people who are affected by these harms. So we center our work on people who do it because we're implementation scientists. So think we center our work on doctors, we center our work on nurses, we center our work on pharmacists, but then we center it also on people who experience it because we're equity focused. So together, this is a transdisciplinary group of people. Actually, what isn't on this lab is that I don't have this on that slide, our state regulator, the State Opioid Treatment Authority, is on this group as well. And that's really important because that's the one voice who actually does regulation for the state. And we work together to plan, to set the agenda for research that we do as a laboratory. The DPRAB also plans the research. We can carry it out. Many people decide what it means and how we want to convey it to partners. And so I'm saying to you, don't be mistaken. This is not an advisory group. This is my board of directors. And these are the people of our lab that you can find more information about us on the web, but we've got folks across the country, actually world, if you count our colleague who is at the University of New South Wales. These are the people, 9 universities and 1 syringe service program, our faculty of the lab. This program also focuses on sex workers. And these folks bring a ton of disciplines to the table: public health, medicine, implementation science, policy science, pharmacy, et cetera, et cetera, et cetera. And together, we also train students and postdoctorals. So we have medical residents from internal medicine. And Dr. Everly, I know, is on the line, and she is a badass. And we also train medical residents in family and community medicine, MD students, pre-med and pre-pharmacy, psych and sociology students. And the students are not just from U of A, they're from Duquesne, UC Davis, Stanford, Indiana University, Amherst, and Western Michigan University. So we're active. The second example I'm going to give you here is around syringe services. I worked in Indiana before we even, worked in Arizona before we even moved here to Arizona, when I was a professor, I should say, at IU School of Public Health. And we were active in changing their law to decriminalize syringes after an outbreak of HIV among people who injected Opana. It was the biggest HIV outbreak in decades. And if you have not heard of this, or you weren't really in school in 2015, just Google my name and TED Talk, and for 11 minutes you'll see what we did. And it's actually shows you the TED Talk shows you the coalition we put together to change that law. I will warn you, you're not going to get the 11 minutes back in your life, but it will tell you the story. So I was working in Arizona because of what we were able to do across the aisle with Republicans and Democrats in Indiana to bring evidence about syringe access and the importance of it to the table for policy consideration. And so partners in Arizona who didn't know me at all yet wanted to bring me in. So I worked with them. This was before the lab was really a thing in Arizona. It was a thing in Indiana instead. So we met with legislators, and what I heard from them was that they didn't believe syringes were needed out in the community because people could buy them in feed stores. So just think about that for a moment, what it implies about humans who need sterile syringes without a prescription to prevent HIV and hepatitis C, or maybe you're getting your syringes for gender affirming treatment and you really don't have a prescription on you right there. You could go to a feed store. So as a researcher and a community, we knew what to do. We met with community members to decide what we thought would be important. We talked about stories told. The colleagues on video did the same, but we didn't have any evidence in Arizona. There was no Arizona base of evidence on harm reduction in 2000. This would have been 2018, nothing. So what we did was a study of people's experiences purchasing, trying to purchase syringes in pharmacies across the state. And so that was very, very important. This is the paper, it's open access. This was very, very important because we had a law that was silent about syringe access. So big P, it did not prevent syringes from being accessible, but you could be arrested for having them. And syringe service programs were illegal because it was a paraphernalia. So this was very important for us to demonstrate that no, people really can't get syringes to prevent bloodborne illnesses. And so this was important for us to work on to change the law. And actually in 2021, the law was changed, or 2022, actually it went into effect. And so Arizona revised statutes actually changed that law. But again, big P policy, there's the law, but our role became clear because as researchers and together with our coalition, we needed to make sure this was being done. So we conducted a study a year later, and we found that, of course, that only a quarter of the pharmacies were actually dispensing syringes without a prescription. So our focus is not on big P when we're still working in this area, because the law allows pharmacy sale of syringes, but on the practice of pharmacy. So we have a NIDA-funded grant. It was a small R03 to study access to syringes at pharmacies. We were able to demonstrate feasibility and preliminary effectiveness of that staff level intervention to change not only the practice of pharmacy behavior, meaning they do dispense syringes when someone comes to them and says, I'd like to buy a bag of 10, and they're asked, do you have a prescription? And they say no. And they said, well, why do you need it? And the answer is not my cat, a lie, anything else. They're saying to protect me from HIV or hepatitis C. And so we know that an intervention is possible and has good opportunity to make a difference. We'll just be conducting a larger study to make that be the case. I talked a little bit about information to or data to information translation, and here's an example of what we did after a census study of pharmacies. So this is all, by the way, with duct tape and shoestring budgeting. Don't think for a minute we have grants for this stuff. This is just extra budget dust that we have, discretionary funding, which incidentally I'm not allowed to spend right now, but I hope to hell that ends. But this is the kind of thing that happens with discretionary funding. In fact, our first syringe paper and study was done by discretionary funding I had at Indiana University and lent to the Arizona effort. This is a pharmacy hot map, which discusses several activities of pharmacies, and 208 pharmacies were in that map, but more are now. If your pharmacy is not here, you can download a letter from me and they can scan in their answers in less than 4 minutes and we update the map. This is important because if you are a prescriber in whatever town you're in and you want to make sure your patient can have curative hepatitis C treatment or pick it up at the pharmacy, or buprenorphine will be dispensed at their pharmacy, et cetera, or perhaps the law will change. We also study the likelihood of methadone dispensing. You could look at that map on a phone, on a tablet. Your patient can too. This is a public resource. Okay, so the final example is what we're working on right now, and that is to normalize methadone. So I said to you, one person dies every 5 minutes of an opioid overdose. But here's the good news. We've got tools to deal with this. And so that's a really important thing to realize. We've got some tools, and that is buprenorphine and methadone. Those are the two safe and effective treatments for opioid use disorder. And here's the best part. Access to them will prevent opioid overdose death up to 60%. In one study, 80%. So it is a game changer. But like you see here, which is a compilation of studies across the country, it matters where you live. And again, this echoes Brenda's talk. This echoes what our colleagues are saying in the video. It matters where you live, and that's not okay. All right. During COVID, there was a policy experiment, and I tell you, I have arguments with a lot of people who don't believe that the COVID treatment, mood treatment accommodations that you're seeing here would be actually done because of anything but COVID and protecting patients. But I'm here to tell you that we have tried to change at the big P policy level, at congressional level for years, the rules around mood dispensing and management, specifically methadone. So COVID hit, we were worried about protection of people, telehealth laws, yes, but there were several accommodations that were allowed for methadone specifically, but also buprenorphine. And so we wondered, okay, how is it going in Arizona? And this was during COVID. So we conducted 2 studies with our DPRAB members across the state, English and Spanish. And we essentially learned, all these are open access, by the way, which, by the way, if you're doing translational research, if you're doing research in health equity, I recognize that it is such a financial, I just have so many words for this. It's a terrible cost to get your articles open access. I know there's court cases on this and I just can't wait till they get settled. But the fact of the matter is, if practitioners in the community cannot access the information, then you've just cut them off and they end their interest at a paywall. And that's disempowering from the get-go. So 2 of our studies demonstrated that essentially nothing much happened in Arizona and COVID. And this is really important because our colleagues across the country in Rhode Island, in New York, San Francisco were saying, oh, it's cool. We're really implementing these wonderful accommodations, et cetera, not in Arizona. And this was why we do this work here with people here, so that we can have evidence to say, yeah, y'all are fine there, but here, not working out. And we need to do work. And so what you see here is a list of 7 things that we were all involved in to translate the data to information, to inform policy. So what you see in these pieces of paper to the right, the first 2, the top right, is really 1 sheet of paper, 2-sided. We published a medical advisory right when COVID ended. And on one side, it was information for patients. On one side, it was information for prescribers to say, you can get your dosing the way you had it in COVID. And if you're not getting that, you need to complain. And then when the federal government did, in fact, make final, now this is small policy, small p policy. They finalized the mood access treatment accommodations that were allowed in COVID and actually expanded them to a really wonderful level to give physicians more autonomy, prescribers more autonomy, and some realistic dosing levels in this fentanyl era. We published a policy highlights. So that was widely used. All of these things are just examples. And I can talk with you about these studies, and I'm sorry if I'm kind of going through them really fast. But here's another example of translation of information to make sure people can access what this is. This is CFR Part 8 is the final federal rule allowing the COVID accommodations to be permanent. And so we give this to providers, we give this to patients, we educate with this. It's just something we created to make the law and the information about it a little more palatable. So it's an important kind of thing for those of you on this call who do research, that you realize that in order to really make a difference in translational science, that study findings have a life beyond the journal publication and beyond the next grant. And maybe it is that you've got people like I had GIS students that built the pharmacy map. And incidentally, the guy who built it, Ethan Chang, got a job with the company that runs the back end of the pharmacy map. So I'm like, well, that worked for him. Awesome. So, things that we can put our teams together to do this extension of our work. We just have to be creative enough to think about it. And frankly, as research leaders, we have to push this organization, this university, into investing in this kind of work. So the outcome from the law change, which is on the left, you can see the law, the federal law, is that Arizona actually also decided to align with the federal dosing. I know this was because of the work that all of us did as a village. What's left is a federal state, a state policy rate alignment. We're working on that now. And here is really the horizon. We're trying to normalize methadone treatment so it's patient-centered, low barrier, pharmacy dispensing, multi-date dosing. We're trying to anticipate the system change with our research. We want to further integrate mood into primary care with statewide expansion. Robert Woodruff, who is a medical resident, is running a study on the likelihood of prescribing methadone and buprenorphine to future patients among Arizona medical residents piping into primary care. Cassandra Everly is also part of that, an MD student too, et cetera. Quality improvement, prescribing and counseling, we're trying to go ahead and do that. My final slide to you before information is, here's the 3 things we do. We educate. We take our data and we educate. We advocate, and this is not a dirty word. This is providing information for influence. When the governor's office asks me to give them feedback about what should happen with opioid overdose funding or what should happen around naloxone, they expect me to have an opinion. And so it's not the university's opinion, and you know what you have to say, and you bring your data and say, well, here's what the evidence shares. If you want my opinion, I think XYZ, but here's what the evidence says. And we empower communities with information. We build tools so that they're accessible so people can take the football and run with it. We partner with organizations, etc. So I know this was really fast. I hope it was not too sleepy for you, but it gives you a sense of just one lab's examples of what we're doing to make a change at structural level with research.